Okay, we can start.
Good afternoon, is it good morning, ladies and gentlemen? Now we're going into this new topic, uveitis. Uveitis, the definition is inflammation of the uveal tissue. If you briefly, I can just go to the anatomy of the eyeball. You know that there is the outer coat, the middle coat, and the inner coat. The outer coat is the sclera and sclera. Middle coat is the uveal tissue, and the inner coat is the retina. So inflammation of the uveal tissue, the middle coat, is what is referred to as uveitis. Inflammation of the uveal tissue. There you are. So we go to this definition, inflammation of the uveal tissues, features of inflammation. When you look at the eyeball, there will be redness, there will be swelling and edema, there will be pain, temperature rise, and the loss of function. Any inflammation, these are features of any inflammation, not only the uveal tissue, but all features of inflammation, whether it's on the skin. You have the redness, you have the swelling, which is due to edema, you have pain, you have a temperature rise or warmth when you touch an inflamed area, and there is also loss of function.
You can continue. Continue with this one.
Types of uveitis. And you can classify the uveitis according to the duration of time. I think we'll finish this first. Just hold on, he's still sorting out one or two issues.
We can.
No, finish off whatever you're doing so that when I bang on. Done? Okay. So the types of uveitis can be classified according to the duration of time. Acute uveitis or chronic uveitis. Two, you can also classify according to the anatomical location on the uveal tissue of the eye. For example, anterior uveitis in the anterior segment of the eye. The anterior segment of the uveal tissue, you are talking of the iris and the ciliary body. Okay. Intermediate uveitis, that's the pars plana. As you are going from the iris, we've got the ciliary body, we've got the pars plana, then you go into the actual posterior uveitis, the choroid. Okay. So intermediate uveitis is around the pars plana area. The posterior uveitis in posterior segment, choroid and retina. So classification can be there. You can say this is anterior uveitis, intermediate, like that. Clinical features of uveitis. Acute anterior uveitis. Most common of the uveitis cases, accounting for how much percentage? 3/4 of all uveitis. This accounts for 3/4 of all the cases of uveitis, the anterior uveitis. What you have is sudden onset, duration of 3 months or less. And in terms of presentation, you have sudden onset of unilateral pain, one eye. Photophobia, uncomfortable in the light once the anterior segment is inflamed. May be associated with lacrimation, where you have tears or water, like you are crying, coming out. The visual acuity usually good at presentation, except in eyes with hypopyon. Those that have got signs of inflammatory cells segmenting in the inferior part of the anterior chamber. Those inflammatory cells segmenting in the inferior part of the anterior chamber, that's what we refer to as hypopyon. External examination of the eye, you have normally serial injection. Serial injection is the redness around the corneoscleral junction, the ciliary area. The cornea is clear, the sclera is opaque. At that junction, that's what we call the serial injection. And normally the inflammation will be on the sclera part, because on the cornea there are no blood vessels. The inflammation will be on the scleral part. But you see corneoscleral junction more on the scleral part. It cannot be on the cornea because cornea is clear, it has no blood vessels. Cornea usually clear. When you look internal eye examination, you have got endothelial dusting. This is inflammatory cells on the endothelium. Which is the endothelium? The inner part of the cornea. So you're going to find cells stuck on that part. Since the cornea is clear, when you look on the slit lamp, those cells which are stuck on the posterior part of the cornea, they look like particles, small particles like that. Those are cells, inflammatory cells. So when you are examining an eye and you look at the clear cornea, you find these dotted, small dotted, scattered cells. It means there is inflammation, there is scleritis, there is uveitis, Endothelial dusting, inflammatory cells on the endothelium, also referred to as keratic precipitates, like they have been precipitated from the cornea. They are not precipitated from the cornea. They are cells, inflammatory cells that are stuck on the cornea. Okay. So endothelial dusting, these are inflammatory cells on the endothelium, also referred to as keratic precipitates. KPs appear after a few days. Aqueous cells, presence of cells within the aqueous humor. You've got the cornea. From the endothelium, you are entering into the anterior chamber where there is the aqueous humor. So there may be, if there is a lot of inflammation, some cells are stuck on the endothelial part of the cornea. Some cells are floating within the aqueous humor. So you see those cells within the aqueous humor. What they are referring to as aqueous cells. Presence of cells in the aqueous indicate disease activity. Numbers of cells indicate the severity. Naturally, the more cells you have, it means the inflammation is more severe. If you've just got a few, there is presence of inflammation, but the larger the number, the severity, the inflammation. Grading of cells is done with a 2 millimeter long and 1 millimeter wide slit lamp beam with maximum light intensity. When you flash that light, you can see cells within that. It's like in a room where you've got dust particles. When light comes in through the window, you will see like dust particles are floating within that beam of light. Same thing happens here. When you put a beam of light there, you will see particles within the beam. Note, improvement of inflammation is defined as a two-step decrease in the level of activity or decrease to inactive. In other words, initial part, when you assess that there is inflammation, maybe after treatment, you come again, you have to assess. If you think the cells have gone down, you can say there is improvement. Or cells are now fewer or completely gone, means there is a complete improvement. So presence of cells indicate disease activity. Because those are cells coming, inflammatory cells coming into the anterior chamber. The less the cells afterwards, it means the disease activity has gone down. If they get more, it means the disease activity is gone up. Worsening is defined either as a two-step increase in level of activity or increase to maximum grade. More or less the same. This is the grading of anterior chamber cells, cells in the field. 0, 1 to 5, well, plus minus. 6 to 15, you grade it as 1. 16 to 25, 2. 26 to 53, over 50 plus 4. You will see this over 50 in a field. It means a lot of cells. So, in other words, you may not be specific that this is 1, this is 2. But you can see that the cells are many, inflammatory cells are many, then it's a higher grade which you give. Aqueous flare. Aqueous flare is due to the presence of protein following the breakdown of the blood aqueous barrier. Presence of protein within the aqueous will give you, when you are shining light there, a flare, because light is being bounced back from those protein material. Hypopion is a feature of intense inflammation. Cells will come out, inflammatory cells will come into the aqueous, but with time, those cells settle inferiorly. And you will find now there is a white liquid level in the anterior chamber inferiorly. That's what we refer to as hypopion. Hypopion associated with blood, may occur in hepatic infection and in eyes associated. But this fluid level, due to inflammation, is white. If there is blood, it is maybe traumatic. So you can have what looks like hypopion fluid level, but it's all blood. That is traumatic. You have again fluid level, but whitish. That's hypopion. It's inflammatory cells. Because that one is hypopion. When you see that blood, it's a traumatic event. Someone punched by unkind people. So other features, hypopion as blood may occur in hepatic infection or in eyes associated with rubiosis iridis or in trauma. That's physical trauma. You find it in people fighting or wanting to fight, then one punch, the chap is all over the show. What is posterior synechiae? Posterior synechiae simply means the iris is stuck posteriorly. If you look at the structure, you've got the cornea, then you go into anterior chamber, you've got the iris, and the small hole in the center of the iris you call the pupil. Fluid can move from the anterior chamber through the pupil into the posterior chamber with no problem, isn't it? Now, posterior synechial means the pupil margin, especially the margin, is stuck because posteriorly what is there now is the lens. Between the lens and the posterior part of the iris is the posterior chamber. Between the anterior part of the iris and the posterior cornea is the anterior chamber. So if the iris is stuck posteriorly, that's posterior synechial. If the iris is stuck anteriorly to the cornea, that's anterior synechial. Okay. So posteriorly there is a lens. It means the pupil can be stuck on the surface of the lens. The edge of the pupil. What is happening is production of aqueous is in the posterior part. After being produced, it comes through the pupil to the anterior part. Then the drainage is through the anterior angle. So pupil is in the center and it moves. Once it gets stuck posteriorly where there is a lens, that's posterior synechial. If it gets stuck anteriorly onto the cornea, which is the posterior surface of the cornea, that's anterior synechial. So any inflammation can lead to synechial, either anterior synechial or posterior synechial. And once it's stuck, it disturbs the movement of the aqueous. Production is occurring, and the movement gets disturbed if there is posterior anterior synechial, because production is from the anterior chamber, is from the posterior chamber. Are we clear on that aspect? Low intraocular pressure may occur due to reduced secretion of aqueous by the inflamed ciliary epithelium. Okay. This is a cross section, slit lamp cross section. This is the anterior part of the lens. It's convex like that. You are going posteriorly. What is this? No, this is the cornea. What is this? The lens must have anterior and posterior. But there is no posterior here. There's just this. This is the thickness of the cornea. Behind there is the aqueous. Cells in the aqueous give a flare, like, because light is striking onto individual particles of the aqueous. That's what we could refer to as aqueous flare and the cells. So if you have a lot of cells there, as you shine your light through the cornea, you will see this. There will be a tingling sense, you see to my light small, because you are hitting the cells which are floating within the aqueous. This is the pupil margin. This is the grading, really grading academic of aqueous flare. It's either 0 grade, no cells, you give it as nil, or just detectable, 1 or 2 cells, you say +1, just detectable. When it's moderate, we're talking of cells you can, as you shine the torch, the light there, cells you can see. If there is hardly any, or maybe just an occasional 1 or 2, it's just detectable. Moderate is 2, marked is 3, intense is just too much. Okay. And the hypopion. This is the pupil margin. This is the pupil margin. This is the ciliary iris. Okay, this is the iris. Fluid level here between the iris and the cornea. This is the hypopyon. The cornea is clear. You are able to see through. You are able to see all this. This is the limbus. This is the cornea. First layer. You are able to see through, and you see this fluid level. This is what is referred to as hypopyon. This fluid level is inflammatory cells because of the inflammation occurring there. It settles down in there as a hypopyon. It's a sign of presence of inflammation anteriorly. Okay, so this fluid level, straightforward hypopyon. And this, where is this? Is stuck onto the cornea posteriorly. These particles, these are keratic precipitates which are pigmented. Those that are not pigmented may be white. You get this pigmentation if they've been standing there for a long time, for a long time. These are precipitates. This is the cornea. This is the precipitates onto the posterior part of the cornea and on the iris there. This is in the anterior chamber. So these are referred to as the mutton fat keratic precipitates. Not that they are really mutton fat. They look like mutton fat, white sort of. So they are not actually mutton fat. That's the point you must know. Clinical features, fundus examination, usually normal, if it's anterior uveitis. Clinical features of anterior uveitis, if you do the fundus examination, it's usually normal because the inflammation is anterior, it's not in the posterior area. You always examine the fundus to exclude spillover anterior uveitis associated with the posterior focus. So if you find anterior uveitis, there is no harm to try and do fundoscopy. Just in case, what appears to be anterior uveitis, the inflammation is actually a focus in the posterior part, and cells, inflammatory cells are found now in the anterior part. It's always really nice to routinely check, because if it is anterior uveitis, you check the posterior part, it's all clear. There's no problem. Duration, completely resolve in 5 to 6 weeks with appropriate therapy, and prognosis usually very good. Complications and poor visual prognosis are related to delayed or inadequate management. If a patient has got this, is not being treated, there is ignorance on people who are supposed to treat the patient, then you can have complications. Otherwise, this is a very straightforward case which you people can treat. Where is my slide? Huh? That's the one. Okay. Chronic anterior uveitis is characterized by persistent inflammation that relapses in less than 3 months after stopping treatment. Long-standing case. Okay. Usually it's insidious in onset. Insidious is like creeping in. It's been there for some time. And many patients are symptomatic until development of complications such as cataract or keratoconus. In other words, the patient may sometimes not be aware that they've got a problem until these other complications come in. That's when they will come. Because, okay, it's inflammation, people, they're avoiding it. No, it's a small thing. But once the lens is affected, cataract is there, your vision goes down. Then you quickly know, I can't see now. You go there and what you find is usually a white eye, examination of eye with slit lamp. You have cornea usually clear, plenty of aqueous cells, varying in number according to the disease activity and severity, usually act as indicator of the more cells you find, it means it has been the issue is a severe case. Probably has been there for a long time. You know? So the cells vary in number according to disease activity and severity. Usually these cells act as indicator of disease activity. The more cells, the more serious the issue is here. Keratic precipitates, we are continuing the clinical size and the features rather. Keratic precipitates, these are clusters of cellular deposits on the corneal endothelium. At the back of the cornea, you find these clusters of precipitates stuck onto the posterior part of the cornea. Those are what we call keratic. It's like they've precipitated from the cornea. No, they are not precipitating from the cornea. They are stuck onto the cornea because of the inflammatory activity in the anterior chamber. They can get stuck on the posterior part of the cornea, or they can settle in the anterior part of the chamber, inferiorly and forming that liquid level. So any inflammatory there, cells can either settle down or get stuck on the cornea. When they're stuck on the cornea, they are referred to as keratic precipitates or KPs. KPs occur in granulomatous disease and have greasy appearance, often more numerous inferiorly, may form in a triangular pattern with the apex up, or long-standing non-granulomatous KPs may become pigmented and less dense centrally. Where is it go? These are pigmented KPs. It means they've been there for a long time. They get that pigmentation. Which one? This? These, they are not pigmented. Mutton fat KPs. Like fat. Okay? These are pigmented. So you have we're talking about, where are we now? Dilated iris vessels. Any inflammation, even in the skin, if there is inflammation, you find there is vessels get dilated. It's a sign of inflammation, that one. Dilated iris vessels, occasionally seen in long-standing cases and resolve with time. Iris nodules may be present, typically occur in granulomatous disease. Those things like TB, you know. Cope nodules, these are small nodules situated at the pupillary border, while Busaka nodules involve the iris stroma. And the large peak nodules characteristic of sarcoid uveitis. I hope I have examples of this. Cope, you can see this one here and this one at the border of the iris. 1, 2, 3. Yeah. These are Cope nodules. These you can see slightly bigger, but they're also there. Like this one there. This is large sarcoid This is the edge of the iris. Iris atrophy may occur, which may be sectoral, just a sector occurring, especially in cases of herpes simplex and herpes zoster iritis. They tend to give you that sectoral atrophy. Duration of the disease, diffuse iris atrophy occurs in Fuchs uveitis syndrome also. Duration of the disease usually prolonged and in some cases may last for many months or even years. Remissions and exacerbations of inflammatory activity are very common. Prognosis guarded. When we say guarded, what that means is they are not sure of the outcome. Maybe, not that everything will be bad, but once you see, you're not sure about the outcome. So what is the outcome? Guarded because of complications such as cataract. You may have cataract, you may have glaucoma, and you may have hypotony. So once these things are there, you know all these things can occur or may not occur. Oh, that's the next one. Okay, sorry. Posterior uveitis involves retinitis, choroiditis, and retinovasculitis. The retina is inflamed, or the choroid is inflamed, and you have vessels on the retina, all showing inflammation. That's what is referred to as posterior uveitis. When it's the iris and ciliary body, we're talking of anterior uveitis, with signs spilling over into the anterior chamber, onto the iris, onto the cornea anteriorly, like that. But posterior uveitis, inflammation of the posterior the retina. It may involve retinitis, choroiditis, and retinovasculitis. Retinovasculitis is inflammatory along the vessels of the retina. Retinitis may be focal or multifocal, geographical or diffuse. Active lesions are characterized by white retinal opacities with indistinct borders due to surrounding edema. As the lesions resolve, the borders become better defined. I'm sure we shall have. There you are. You can see a white patch. That's acute retinitis. Where does it finish? Maybe somewhere here. Maybe the borders are not distinct like that. That's what it means. What is this? Yes, it's not retinitis. But this is choroiditis because you've got blood vessels right across the lesion. If it was the retina, this blood vessel wouldn't be there. It's below the actual retina. It's the choroid. Okay. Vasculitis along the blood vessels. You can see like, what can I say? Like exudus along the blood vessel. This is where the blood vessel is. See this white stuff on either side. See the white stuff along the blood vessels on either side. It's not inside, it's outside. But it's because the blood vessels are inflamed. And that's what you get, acute vasculitis. Oh, go down there, sorry. This is the one. Choroiditis may be focal. Choroid is below the retina. You've got the retina, then choroid. Choroiditis may be focal, multifocal, geographical, or diffuse. It does not usually induce vitritis in the absence of retinal involvement because choroid is there, above that is the retina. Okay, so it cannot, you can't have inflammation of the vitreous unless the retina is also involved, because between the choroid and the vitreous there is the retina. So acute choroiditis is characterized by a round yellow nodule. Vasculitis may occur as a primary condition or as a secondary condition adjacent to a focus of retinitis. Okay? Both arteries and veins may be affected and venous involvement more common. Active vasculitis, vessels being inflamed, is characterized by yellowish or gray-white patch perivascular along the blood vessels, those patches of white stuff along the blood vessels. What is called the perivascular coughing, which may be associated with hemorrhage. Once you've got that white stuff where the vessels are running, that is active vasculitis. Principles of treatment in uveitis. General principles. Immune-mediated uveitis involves use of.
It's remaining with less than a minute to be
So
cut off. So we just prepare
for the next one. Okay, no problem. Principles of treatment. We'll come back
So
when we are sorted again.
They should just be advised to ask their questions in the next session.
In the next session. Let's have the questions in the next session, guys. Ready?